Thank you for joining us for the third annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcomes, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Jennifer Jones, and I am an AAKP Board of Director, Executive Committee member, and ambassador. I'm also a resilience coach, speaker, and a retired Marine Corps veteran. 10 years ago, I was diagnosed with membranous proliferative glomerulonephritis type 1 idiopathic after exhibiting symptoms of acute kidney injury, or AKI, while deployed to Afghanistan. Throughout my journey, I've experienced AKI numerous times due to this disease. In fact, this January, I returned to peritoneal dialysis after having 5 years with a kidney transplant. If it weren't for the nephrology team of Walter Reed National Military Medical Center, I may not be here today, and that weighs heavily on me. However, I am hopeful that one day the focus of my treatment will change from mitigating disease to preventative medicine and modalities. As health consumers and the center of patient-centered care, it is crucial that we provide input and gain access to new kidney care innovations. Being part of AAKP allows me access to the education and resources I need to not only improve my quality of life as a patient, but also the platform to use my voice and my experiences in a meaningful way to demand more innovation and more choices for myself and others diagnosed with chronic kidney disease. As an AAKP member, you can do the same. It is critical now that we as patient consumers raise our voices and create demand for new diagnostics, devices, and biologics in our independent countries. By cultivating a united patient consortium, that demand can be supported globally for patients in countries where healthcare systems and/or infrastructure may not support patient consumer choice and/or access to care and treatments. Today, I am pleased to introduce friend and ally of AAKP, Dr. Rajit Basu, Associate Professor of Pediatrics at Emory School of Medicine. Dr. Basu is Research Director of the Division of Pediatric Care Medicine at Children's Healthcare of Atlanta, and he serves as a steering committee member for the No AKI campaign, a bioMerieux-supported global campaign. For our session on Evolving Science, Implications of Acute Kidney Injury on Long-Term Kidney Health. Dr. Basu, you may start your presentation.
Hi, my name is Raj Basu. Thank you for joining this global summit. I'm excited to talk to you today about acute kidney injury, and specifically about the assessment of AKI knowledge in a study that we did and the data that we have, looking for educational opportunities as we move forward to help diagnose and manage acute kidney injury in critically ill patients. I have a couple disclosures to make sure I tell you about. The most important is that some of the work I'm going to be discussing was just recently completed. It's not yet published, but it was supported by the Ipsos data management company and also bioMerieux that is involved in the AKI space. And I get there's no royalty or anything with this data. It's really just me. I do consulting for acute kidney injury. So over the past decade, we've really made a case for the idea that acute kidney injury is important. We have data set after data set that shows, as I'm about to, that there's increased morbidity and mortality independently associated with AKI. We also know that AKI independently adds up to costs that are exorbitant in hospitalized patients, almost to the tune of $10 billion per year in the US alone. We know that acute kidney injury increases your length of stay by almost 3 to 4 days. We know that hundreds of thousands of people die every year with acute kidney injury. What we don't really know is what we can do about it. Recently, there have been a number of movements trying to get more people aware of both the problem of AKI, what we can do to recognize AKI, how we can manage AKI. And the American Society of Nephrology put together what they call a toolkit, or a series of interventions geared toward the idea of improving awareness, recognition, and management of AKI, improving education, generating guidance on AKI evaluation and management, developing a toolkit, engaging hospital administration, and raising awareness of the fact that AKI leads to complications not just in the short term, but also in the long term. More recently, I think we have all been hit in the face pretty much with COVID-19. And in the world of critical care nephrology, we know very well that acute kidney injury in the setting of COVID-19 makes all the outcomes worse. Even though we've gone through a series of learnings in our first wave, second wave, of third wave, whether you're in the Western Hemisphere, in the Eastern Hemisphere, in the Northern Hemisphere, in the Southern Hemisphere, what we know is that acute kidney injury in the context of COVID is worse for you. Not only in the short term, as morbidity and mortality go up in those patients who have some form of AKI, but also with relation to progression to chronic kidney disease. If we just take a step back and look at the data across populations, these are the big four studies across neonatal, pediatric, young adult, middle-aged adult, older age adult, across the globe, studying the incidence and prevalence of acute kidney injury and patient outcome. And quite startlingly, almost all the data is almost the same. 1 in 4 acutely ill patients, regardless of age, regardless of severity of illness, have some form of AKI. And there's an independent association with AKI and poor outcome, a dose response, so to speak, that more AKI is associated with more death. And we just know that in our world of critical care nephrology, this data is loud, it's strong, and it's powerful, and it's repetitive. We have more and more data that shows us almost the same thing. What we also know is we're limited by our tools at our fingertips. If you look at the diagnostic things that we have, whether they be creatinine as our major diagnostic variable, urine output, glomerular filtration rate, either directly measured or indirectly measured, we know that there's quite a bit of variability with muscle mass, volume contraction, fluid state. This is made worse in patients who are acutely ill, which is most people who have these things measured, in pediatric patients who don't have a baseline, and in neonates who hardly have anything measured. So what we're dealing with is a black box of diagnostics, of understanding what the disease is for disease that causes a lot of problems. But what we need to understand is what we don't know. We think we know quite a bit, but what we are missing is the idea that we can't tell what non-nephrologists, non-intensivists know or don't know about AKI, because we would think that potentially there's a knowledge gap. So there is a big possibility here. If we could really understand gaps of knowledge for people who are, quote, not the bully pulpit, not the choir, we're not preaching to the same people we preach to, people who are not intensivists, not nephrologists, about the data I just showed you about the problems with AKI, it may identify new opportunities to raise awareness in the hospitals and beyond, because as you know, many people in the hospitals are varied degrees of discipline of different medical subspecialties and also walks of life. Improved awareness may be crucial to what we as critical care nephrologists believe to be true. Considering AKI as a problem, recognizing that it's either subtly happening or in your face, prophylaxing and preparing against AKI, mitigating the effects, and managing AKI. It allows us to be more proactive than reactive. So what we conducted in the fall months was a study across Western Europe and US looking at healthcare providers and what we considered AKI awareness. Again, this study was supported by the Ipsos group and by bioMerieux. So what we did was a survey-driven study of healthcare providers across 3 paradigms, what we called AKI Impact, knowledge of acute and chronic associations with AKI, familiarity with AKI itself. What is the current status quo for diagnostics, what people do management, what they believe to be true. And then the third, which is what could be true. What are people interested in? We studied these 3 paradigms in unison. So we looked at about 1,000 practitioners from the US and Western European countries, as you see here. They were divided amongst intensivists and nephrologists that we thought would be positive controls, people who knew all about AKI, emergency room physicians, cardiologists, and then your ward physicians, the hospitalists, internal medicine docs who manage patients for all across the board for different things. All 5 of these groups of physicians all deal with acute kidney injury to some shape or form. We had screening criteria that mandated that they worked a certain period of time in the hospital and a certain qualification level and be involved in decision making. And again, the study was conducted in the fall months of 2020, and it was a simple 15-minute online interview of people that had already signed up to be part of a survey kind of driven study site. And this is what we found. Of all the people that we surveyed, The hospital size was quite varied, but most people worked at hospitals that were notable, above 100, 200 beds. Most of the units had at least an ICU, emergency department, or dialysis unit. As you can see, about 2/3 of them had all of them. A lot of them had ICUs that were quite large in size. Almost half of them had a hospital that was an ICU of at least 30 beds. Many of them dealt with many AKI patients. Most of them were adult providers. And we looked at, as I said, the different paradigms of AKI. What did we find? Believe it or not, almost half of all providers, and this included nephrologists, this included intensivists, are not even using the term acute kidney injury to denote an increase in creatinine or a decrease in urine output. Please remember that AKI was introduced as the new way to name kidney injury in 2004. So 17 years later, what we're dealing with is half of providers out of this 1,000-person survey were not using AKI. They were calling it acute kidney failure, acute renal failure, or other things, knowing that AKI is the term that all of us as critical care nephrologists are putting out there to each other that we should be talking about. If we look at AKI Impact alone, what you can see is we compared knowledge of AKI next to things like sepsis or a stroke or a heart attack, things that you would think most people understood. In the sense of very familiar, it is this idea that you understand what a patient looks like, you understand what you might do. Now, obviously, the disciplines were varied. If a nephrologist saw a heart attack or a cardiologist saw AKI, it was different. But if you look at the knowledge of an intensivist, a hospitalist, an emergency room physician, it was varied. If you look at the AKI is common in the ICU or outside the ICU, it was varied. Most people agreed that it increased both morbidity and mortality. Most people agreed that the cost of managing AKI was high, but as you can see, this varied quite a bit between subdiscipline. Emergency room physicians, hospitalists were not aware of how much money AKI costs. The other thing is, if you look at the bottom tab where it says leads to chronic illness, you can see that nearly all of the non-nephrologists were not aware of the long-term consequence of AKI. In this situation, we know that probably 20 to 30% of patients who have some form of AKI have chronic kidney disease. But if you ask an emergency room physician this, or a hospitalist this, or a cardiologist, many of them were not realizing this. But almost all healthcare providers agreed that early detection of AKI can lead to better outcomes. So in these specific statements about detection of kidney injury, being able to detect that before damage occurred can improve outcomes, or not recognizing AKI can lead to significant problems, or there's a stronger need for education, most of the people agreed. And those people who use management guidelines are more likely to agree that not recognizing AKI early can have a bigger financial impact on the healthcare system. So the current state, and in a state that may not be overly fascinating to us in some ways, I would say that we found something dramatic in the sense that 3/4 of nephrologists and intensivists indicated that some cases of AKI were missed at that hospital. Now, if you put it into perspective, if you said that 3/4 of them believed that cases of sepsis or heart attack or stroke were missed at the hospital, that would not be something that people would tolerate at all. More so, many of the subspecialties indicated that current methods for the diagnosis of AKI meant that diagnosis was often missed. Now, it was interesting that the nephrologists and the intensivists felt more strongly about this than the hospitalists and the emergency room physicians. So the experts in the field believed that we're missing AKI, but the people that are not in the field believe we're not missing AKI, which creates a big problem of the people who don't know that they don't know. And if you look at the bottom, and if you look at this idea of management of AKI in terms of nephrology consult, hospital protocol, KDIGO guidelines, which are the management guidelines that have existed since 2012, so almost 10 years. What you'll see is that a majority of intensivists are not following any kind of protocol. Half of them will call nephrology, meaning most of them do it on their own. Majority of hospitalist physicians ED physicians are not following any kind of guidelines, not following any kind of protocols to recognize and manage AKI. A majority of people do feel that changes in creatinine are not sensitive nor specific for AKI. And many of them indicate that tools available for the early detection beyond creatinine and urine output were insufficient for their needs and desires. And as you see to the right, the comparison of the United States and the Western European countries showed not a lot of dissimilarities between those regions. We draw attention to this idea that more than half believe that AKI is missed. More than half believe that urine output is not specific for AKI. More than 80% believe that AKI costs a lot. Internists, pediatric practitioners, nephrologists, cardiologists all vary with how much they believe in the diagnostics, how much they believe in the guidelines, how much they're using. This varied all across the board. Probably one of the most startling findings was that of the people that indicated, yes, we are missing AKI, 1/3 of the cases that they believe they were missed could have been prevented. That is like saying that, hey, we had 10 patients today. We missed a significant proportion of them with sepsis. We could have prevented the sepsis had we recognized it, managed it in time, diagnosed it in time. This is an opportunity for improvement for us. As I mentioned, the KDIGO bundle guidelines, which have been in place for the last 10 years, less than 50% of healthcare providers are using these guidelines. So the potential, what we could do. Almost all providers indicated they would like to learn more about prevention, detection, and treatment of kidney injury. Most of them, probably a little more than half, in some disciplines, and looking overall at the United States and Western Europe, believe that knowledge of AKI is poor outside of critical care medicine. If you look at nephrologists and intensivists, again, those of us who believe that we are experts, we believe that people outside of our fields don't know. And the people who are outside of the fields who don't know that they don't know. And this is evidenced by the fact of the steps used to monitor AKI. So if you look at the bottom row, those are the steps involved in the KDIGO management guidelines. And what you'll see is cardiologists, hospitalists, emergency room physicians, even nephrologists and ICU people. As you go down the list, people check the boxes of those things less and less and less. You think about the specific ones, such as alternatives to contrast for patients with AKI who need CT scans and need radiology with contrast. The people who are administering those drugs or ordering those scans are often the people in the emergency department, often the hospitalists, often the cardiologists who need to catheterize patients. Those are the patients who could make a difference in adjudicating AKI mitigation steps. In this cumulative agreement graph, what we're showing you is the proportion of healthcare providers who agreed to the following statements one by one by one by one by one. AKI is associated with morbidity and mortality. Most people. Current AKI diagnostics are imprecise. Less people, but still a decent amount. We miss AKI. Tools outside of creatinine urine output are insufficient. We keep delaying our diagnosis, which leads to poor outcome. And if we could improve that, it would improve outcome. What you see at the end is a separation between intensivists and nephrologists and emergency room physicians and hospitalists, in the sense that the experts in the field who know the epidemiology, who know the recent data about diagnostics, who know the management guidelines, feel much stronger about the idea that all these statements are connected to the people outside of the field, something that we can improve upon. So this slide also shows an agreement slide where we looked at proportion of healthcare providers who strongly agreed to the idea that creatinine and urine output changes may not be the greatest test for real-time diagnosis of AKI, and the concept that we're missing cases, diagnosis is delayed, and that we can improve outcome. As you can see, the agreement shifted between subdiscipline for the missing cases and delayed cases, but it was robust in the idea that we could improve outcomes if we could detect injury before damage actually occurred, i.e. preventative medicine, i.e. the idea that we recognize stroke symptoms before true damage is long-lasting and occurs, the idea that we can recognize signs of a heart attack before someone has serious heart damage. So our big summary findings. We found a wide range of understanding with familiarity with AKI, understanding AKI impact, both short-term and long-term, fairly unison point of view that AKI was a problem in the short term, that diagnostics we have could be better, and that outcomes could be better. Quite a bit of variety in the sense of AKI leads to long-term problems, and of quite a bit of variety in terms of who's following the guidelines that were issued a decade ago. So what are our take home? What do we take from this data? What do we take from the data that we have, that as critical care nephrologists, we have tons of epidemiology that shows us AKI is bad, severe AKI is worse, AKI in the context of critical illness is terrible for you. Healthcare providers agree that it's an important contributor to patient morbidity and mortality. But we have a long way to go to understand that everyone understands what we understand. The diagnostic adequacy should be improved. There's a lot of desire for education. There's a lot of education that needs to happen with regards to KDIGO management guidelines. And so we do have some clear opportunities to raise awareness for AKI and integrate this idea of more personalization of medicine for the concept of AKI and critical illness. And with that, I'll stop, and I appreciate the chance to speak to you today, and I'd like to acknowledge people and invite everyone to be a part of our Pediatric AKI Nexus.
We appreciate Dr. Basu for his taking the time to share his insights and expertise. Thank you.